within the stomach. And so we discussed the possibility of doing an endoscopic retrieval, but based on the size of the ball and the equipment that we have available, the owners have decided, and we've decided, to recommend an exploratory laparotomy and just get to the bottom of the problem quickly and easily. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So we're going to start with a midline abdominal exploratory, and I'm always going to go up to the xiphoid, which is sitting right there. And I'm going to go down to the prepuce in male dogs. In female dogs, we go down kind of halfway between the pubis and the umbilicus. Now, this bruising here is, we've done a line block beforehand on the advice of our emergency vet who's admitted the patient, who's here with us, Claire. I normally had not done line blocks, but I think it's actually a really good idea, and anything that we can do to reduce the sensation of pain during the surgery is going to reduce the dose of the anesthetic that we're going to need, and so that's always a good idea. So midline abdominal exploratory, we're going to go right through the linea, and Cindy is suctioning out some of the smoke. And there's never been a study, to my knowledge, that's shown that surgeons have an increased risk of respiratory cancer and things like that. However, they have analyzed the smoke from electrocautery, and it is pretty nasty stuff. It has arsenic in it, and it has cyanide in it, and some mercaptans and some other nastiness, and so probably makes sense to evacuate it and not have it going up into our nostrils. So I have penetrated the linea here, and the reason I can do that with the cautery is because the falciform is deep to the linea and is protecting our organs from damage. So I'm trying to stay midline. It's not absolutely critical, but it does make for a little bit easier closure later on. Now the next thing that we're going to do is remove the falciform. So I have the falciform here, and we're going to use electrocautery. We're going to cut right along the avascular area that's right up against the linea. The other thing that I'm going to do probably on the way out is block the linea as well. All right, so, and radiographically the foreign body was in the stomach, and we like it to stay there because a gastrotomy has a lower risk of complications than an enterotomy. Reason for that is that the stomach is basically sterile because of the gastric acid, and also we've got two sets of two really robust layers that we can close the stomach in. All right, now when you're removing the falciform, there are two little vessels on either side that if you don't cauterize them, you're going to have bleeding. So there's one right there, there's the other one. You're going to have bleeding into the abdomen, and so it's not dangerous bleeding, but when you go to close and you see this drip, drip, drip of blood and you don't know where it's coming from, it can be kind of frustrating. All right, so I've gone all the way from the xiphoid basically down to the pubis, extend that a little bit farther. Then I'll put in my Balfours. I always use Balfours, and I don't use lap sponges between the linea and the Balfour. The reason why is because I was trained at Colorado State University by a surgeon named Steve Withrow, and his opinion was, which would you rather have against your linea, stainless steel or a burlap bag? And so that is why I don't. Now, we're close here to going through the diaphragm, but not through it, so we're safe there. All right, so you can use a spoon Basically, all the spoon does is keeps the bowel force centralized. So it just helps keep them from twisting. And as long as it's not going to get in the way of my exploratory, the spoon's a bit funky here. All right, so it's not getting away. I can already see the ball there in the stomach. I don't know if you guys can see that. All right, so the first thing I'm going to do is I'm going to ignore the ball in the stomach, which is sitting right there. And I'm going to do a complete exploratory. So, and I have found things on complete exploratory that I wasn't expecting. So we haven't done a CT on this dog. So, you know, like a diaphragmatic hernia, I've picked up incidentally. I've picked up hiatal hernias. I've picked up portosystemic shunts. So you always want to look at the diaphragm. Now the liver looks beautiful. The gallbladder is easily expressed. I don't know if you guys can see that. My fingers are all up there and expressing that gallbladder. Now I'm going to look at the cardia of the stomach because some tumors form frequently in the cardia. Okay, and then I'm going to come around to the pylorus. You can also have tumors in the pylorus. And then I'm going to exteriorize my duodenum and make what's called a duodenal basket. All right, so I'm going to collect all of my guts and hold them in the basket. So now we can see the pancreas sitting here, and the duodenum is acting like a really nice retractor. I can see the portal vein right there, and I can see the vena cava right down there. Hepatic artery is sitting right there, and I can see the kidney right there. You guys might not be able to see that. Now I'm going to come around the caudal duodenal flexure, and we can see this structure right here, which is the duodenal colic ligament. I don't know if you guys can see that. Let me just... Okay, so right here, in focus. So that's the duodenal colic ligament. I don't know why that's not in focus. There we go. And then come around the caudal duodenal flexure. So the duodenal colic ligament keeps us from exteriorizing the caudal duodenal flexure. And you can break down that ligament if you need to. There's no problem. There's no big vessels in there or anything. So now we're going to run the bowel, make sure he doesn't have another foreign body. You can see that structure right there. It's called a Peyer's patch, which is a lymphoid follicle in the, there's another one, in the small intestine. So nice big Peyer's patch right there. So running the whole duodenum. The other thing we want to do when we're looking at the duodenum is look at the mesenteric lymph node, which is sitting right there. That looks completely normal. And as we run that bowel, we're going to get to the point where we can see a blood vessel on the antimesenteric surface. And this dog does not have a big one. Can hardly see it at all, but that antimesenteric vessel defines the extent of the ileum. And we've got the cecum sitting here, and then we're going to exteriorize the colon and use the colon as a retractor, a colonic basket, and that's going to allow us to see the other side really clearly. Now, I don't know if you guys can see that. That's the phrenico-abdominal vein running over the adrenal gland right there. So it's a really nice view of the adrenal gland. We've got the left kidney and the colon extending all the way down. So I'm happy with that exploratory. If I had any concern about urinary signs, I would do a parapreputial incision to get down to look at the urinary tract. All right, so now we've got our stomach sitting here. And what we're going to do is we're going to pack off the stomach first. And Cindy has prepared some moistened lap sponges for us ahead of time. And we'll come in on the... Is that wet already?
This is also wet.
Okay.
Do you want another one?
Nope. We're good. So we're just going to pack this off to try to reduce the likelihood of contamination. All right, so nice, beautiful, big ball there. So now we're going to get some of our 3O PDS. And I'm just going to put in some stay sutures. And I really like stay sutures whenever I'm operating on bowel because it allows me to control the bowel a little bit better. It keeps it from wobbling around. So we'll just get a hemostat. And you know what we can do? We'll just grab a hemostat, please. Yep. And then the other nice thing about having stay sutures, I might actually extend this one out a little bit farther. The nice thing about stay sutures is that when we go to close a linear incision in the stomach, if you have stay sutures and you put tension on it, it's going to be much easier to place our needle for accurate closure. Just come down over here to the other side. And I'm trying to put my incision in an avascular area of the stomach, so it's going to bleed less. We'll get another hemostat, please. Go right up to the end of my, yep. All right, and cut there. All right, so now we'll pull that up and out, and we can see that we're elevating the stomach nicely. And then the other thing that I can do is we'll get suction getting ready, and go ahead and pull on that. If we put it under tension, it's also going to be a little bit easier for me to cut into the stomach. I know I've got that ball deep to it, so I know that I'm not going to cut through to the other side. Now, even though I thought that that was avascular, we still are getting some hemorrhage. It's annoying hemorrhage, not scary hemorrhage. And that will stop. I had just gone through the seromuscular layer. Alright, so now what am I most likely to be able to grab onto that with? Here we go. How much fun is that? Come on. Okay, so we've delivered the baby. Okay, and I'm just going to drop this on the table back here. Can I get another 3O PDS, please? And just did a little double cut on that mucosal layer. So now when I go to close the stomach, I'm going to do a mucosal submucosal layer first, and then a seromuscular layer. You can close it all in one, but go ahead and pull that out, please. But I like to close it in 2 layers because I'm not in any hurry. I know that that's going to give me a little bit more secure closure. So again, by putting tension on the stay sutures, that suture line is going to be nice and tight, and it's just going to be easier for me to accurately place my sutures. Go ahead and cut that one. Give me about 4 millimeters, please. All right, so now switch from that one to this one. Yep, and so by maintaining tension on that, it's going to make it easier for me to close. All right, so I'm just grabbing onto that mucosa, submucosal layer. And I'm going to use my thumb forceps to direct my loop exactly where I want it. The other way you can do it, I don't know if you guys can see this, but what you can do is as I'm pulling, I can hook my suture with the needle and then use my needle to direct it exactly where I want it. It's a couple of different tricks. Thumb forceps is nice because it maintains tension on the suture while you're pulling it tight, and maintaining tension on the suture is how you make sure that you're not going to have a leak. I'm going to go ahead and suction out our saline. We'll get some warm saline, please. Technically, I don't even know that we need to lavage this because we've had no contamination, no leakage. Pull on that. Going forward, if you guys are watching on VetDojo, please subscribe to VetAlign, because at some point I'm going to transition to just streaming on VetAlign. And so if you want to get notified of my live streams, you'll have to have subscribed to VetAlign as well. So you see how Claire is keeping tension on that suture, and that's keeping my suture line opposed really nicely. And then the next suture layer I'm going to do is called a Cushing pattern, and that's going to be an inverting pattern that I'll use on the muscularis and serosa. In this big dog, my bites are about 3 millimeters apart, 4 millimeters apart maybe. And probably closer to 3. And just overlapping that end by a little bit. I always want to do 5 throws at least. Okay. Sop up a little bit of that blood. So post-operatively, there's a question, how long do we keep them hospitalized? So I'm going to feed this dog in about an hour or 2. So straight away. And if it's not vomiting and it's eating tomorrow, and since it's a Labrador, it will likely be eating tomorrow, I'm going to send it home tomorrow probably. I'm a big believer in getting patients home as quickly as possible because they're going to thrive much better in their home environment. So I'm just doing a little inverting buried knot here. And definitely no antibiotics in this dog post-operatively. There's no reason. 4 mil. No reason to put this dog on antibiotics. All right, so now I'm deep. I just need to do a deep to superficial layer here. And then just keep a bit of tension on that guy.
You can take this.
And then I'm just doing a longitudinal bite, just seromuscular, and I'm not going into the lumen. And that makes it a Cushing. If you go into the lumen, it is a Connell. So what you'll see is that as I take these bites, it's going to invert that seromuscular layer. And cover up that mucosa, or that submucosa that we're looking at. Now the holding layer of the stomach and every part of the gastrointestinal tract is the submucosa. The only way you can make sure that you're getting the submucosa, which I did on the previous layer, is to go all the way through and into the lumen. But on this one, I'm just trying to create a seal. And see how nicely that's inverting. Did we get warm saline already?
Yes.
Great. And I always use stay sutures in any organ that has a lumen. So if I'm operating on the bladder or the small intestine or the stomach, the colon, I'm always going to use stay sutures. Can I please have some OPDS? Okay, quite long. Go ahead and snip out our stay sutures. For the local block, and go right near the stomach. Yeah. That's fine. I use just bupivacaine for the local block. All right, so that looks terrific. And now we will get our suction going. Get a little piece of, I bet it's a little bit of Eshar. All right, so go ahead and do our suction. I mean, you can just pour in the bowl. There's a comment about whether I can add the VetAlign link to this video, and I definitely can. So if you look in the description of the video, I hope to remember to put a link to VetAlign. So lavage with saline does a couple of things. It dilutes out any foreign material. It also helps us identify if there's hemorrhage. Because if we were suctioning this out and getting frank blood, we would know that there's a bleeding vessel down there that we would need to address. All right, so now when we go to close, we have to make sure that we are closing the actual linea and not the false linea. And I'll show you where the false linea is. So that is the false linea. Okay? False linea. If you close to that, you'll have an abdominal hernia. We need to close the real linea up there. And I'm just going as far caudal as I can. And you don't need to get a lot of it. If you get like 3 mils of true linea, that's more than enough. And I'm just using OPDS in this dog. There are some surgeons that would say that even OPDS is overkill. Okay, about 4 mil. Yep. Lift up on that. So, post-operatively, we're going to have this guy on meloxicam, paracetamol, methadone overnight, and I'll talk to the emergency guys about whether they want or they think it would be appropriate to have a fentanyl patch on. I probably would, but I know that some people shy away from them because they have unreliable release. Would you guys normally put a fentanyl patch on? Yeah. So we will go ahead and put a fentanyl patch on. Can I get some bupivacaine, please? How much did we use for the cutaneous?
Cutaneous, I think we used about
2 mil or more?
3 mil.
3 mil? All right, so then I'll have another 3 mil to use on the linear block. And a lot of people ask me, oh, do you close this in 2 or 3 different segments with knots in the middle? My feeling is that if I'm confident in my knots and in the suture material, the knot is actually the weakest part of the suture. Also, if you have a third of this incision dehisced or you have the entire incision dehisced, it doesn't really matter, right? Because you're going to get a hernia or you're going to have like evisceration. And so I do not tie these off 2 or 3 times in the middle of the incision. I just close it in one straight, simple, continuous suture pattern. Another question that some people have is, do I do an omental patch on the stomach? I generally do not. However, whenever I operate on the small intestine or the large intestine, I'm always going to use a fentanyl patch. an omental patch. And the reason for that is that the stomach very rarely dehisces. It's sterile. We've got 2 very secure layers that we've closed. And so I'm not too concerned about that. But with a small intestinal dehiscence of an intestine, that's catastrophic with peritonitis forming. And when you get peritonitis, the mortality is 50 to 75%. So the risk of leakage with the small intestine is higher and on those.
And do you tack it with suture?
Yes. Yeah. So Claire's asking if I tack it with suture to the small intestine, and I do. Some people just drape it over. I just feel like if I'm in there, it'll take me an extra 2 minutes to just go ahead and suture it down, then I know exactly where it's going to go. The other thing I've had happen to me before is if I don't go far enough cranial with my closure, you can get a little hernia cranially right at the xiphoid. So you have to make sure that you go far enough forward. So that I can still get my finger in there. So I'll take a few more bites. Now the link for VetAlign is just, it's YouTube at VetAlign. So use the little at symbol. And VetAlign is spelled VETALIGN, VetAlign. Get some more OPDS, please. All right, so we've got our extra bupivacaine here. Bupivacaine is 2 milligrams per kilogram, is that correct?
1 to 2 mg per
Yeah, 1 to 2 milligrams per kilogram. So I'm just going into the linea with my needle. And then I'm aspirating each time because arterial or venous bupivacaine is really bad news. False linea. So again, that's the false linea right there. I feel like I wet myself. Did some saline pour out. How embarrassing. Somebody did ask the serosal patch for the stomach. We've kind of created our own serosal patch by doing that Cushing suture pattern, inverting suture pattern.
Do you sometimes engage muscles underneath to decrease seroma? Is that a thing? Because I've heard it.
Yeah, I don't really. I stand corrected. Actually, I do that sometimes if I feel like there's a big pocket there. In a case like this where there really is not any pocketing, then I'm happy not to. Question was whether I tack my suture line down to the linea. See how I've got a little bit more skin there than I do on that side? So what I'm going to do is I'm going to spread my sutures a little farther apart on that side and closer together on this side. And you'll see that within a couple of bites, it'll have corrected that disparity. All right, do we have some, can we get some 2O PDS, please, on a taper needle if we've got it? All right, and I'm going to leave Cynthia to close the intradermal layer, and I'll come over and make sure that there aren't any questions. I am definitely going to be streaming again this week. Nothing else today, but I've got several other cases coming in tomorrow and the next day, so I will be streaming some more. I'll just go back and make sure that there's nothing that I haven't answered. All right, so if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. And we will see you again tomorrow, hopefully.